Good evening to everybody present here. I would like to thank the AIOS committee for a chance to speak at this platform. The topic for my case presentation is a rare case report on crouzon syndrome. Crouzon syndrome is an autosomal dominant disorder characterized by craniosynostosis of coronal and sagittal sutures, which begins in the first year of life. It was first described by a French neurosurgeon, Octave Crouzon, in 1912. It is caused by mutation in the fibroblast growth factor receptor 2 gene, FGFR2. Now the case report. A 6-year-old male child presented to the ophthalmology OPD with chief complaints of protrusion of both eyes since birth. The mother of the child also reported that the child often complains of headache and constantly rubs his eyes. HOPI, the patient was apparently symptomatic since birth. The mother noticed prominence of both the eyeballs, which was progressive in nature. The prominence was not associated with any pain. There was no postural variation in the prominence. There is no history of skin discoloration or hyperpigmentation of lids or eyes, fever, headache, nausea or vomiting, dysphonia, dysphagia or easy fatigability. There is no history of radiation or chemotherapy, nasal block, frequent RTIs or epistaxis. Past history. The child was born at the hospital. It was a full-term normal vaginal delivery. The baby cried at birth and all his milestones were achieved at normal time. There is no history of any systemic illness. Personal history, patient consumes a mixed diet and his bowel and bladder habits are regular. The father of the patient also has similar complaints. On general examination, the vitals were normal. There was no pallor icterus clubbing or cyanosis, no lymphadenopathy. All systemic examinations were within normal limits. The positive findings were the mental status of the patient was normal. There was shortening of the AP skull diameter, frontal bossing was present, mandibular prognathism, parrot beak nose appearance, and there was a high arch palate during intraoral examination. An ENT examination was also conducted, which revealed a mild conductive hearing loss. Ocular examination. Best corrected visual acuity was 6/6 partial in both eyes. Bilateral proptosis with hypertaylorism was present. Navzinger sign was positive. Extraocular motility was complete in both eyes. Lids were normal, conjunctiva was normal, the cornea was clear, and the anterior chamber had normal depth. Iris, there was normal color and pattern observed. Pupils were round, reactive, and regular, and the lens was clear. This is the image. The IPD of the patient was 75 millimeters. We can see there is a shortening of the AP skull diameter. The jaw is prominent, and there is hypertaylorism. This is the intraoral examination, which reveals a high arch palate. There was a proptosis of 35 millimeters. This is the image of the father of the patient, and he had similar features. Investigations that were carried out were, the hematological picture was within normal limits, thyroid function test was normal, urine analysis was normal, and Cassoni's test was negative. And MRI brain with orbit was done. On this, we can see that the patient has bilateral proptosis, the orbits are shallow, and there is hypoplastic maxillary sinus. In this image, we can see dilated ventricles, which is indicative of mild hydrocephalus. Over here, we can see there is an irregular shape of the skull. This is due to premature closure of the sutures. On X-ray during Waters view, we can see a copper-beaten skull. Management, multidisciplinary approach was taken. Early craniotomy is advised to prevent and to treat raised ICP if present. If needed, mid-facial advancement and jaw surgery can be done. Prognosis depends on the severity of malformations. This patient was further referred to neurosurgery department and the plastic surgery department. The differential of this case is Apert syndrome, Pfeiffer, Jackson-Weiss, Carpenter, and Sethre-Chodson. This is probably a case of crouzon syndrome. Crouzon syndrome has an autosomal dominant inheritance pattern with variable expression. Mutation in the FGFR2 gene, which maps to chromosome 10, Q25, and Q26 are responsible for all cases. The incidence is 1 in 25,000 births throughout the world. It constitutes 4.8% of all craniosynostosis cases. There is no sex predilection. Other features of crouzon are proptosis caused by shallow orbit with or without divergent strabismus, orbital hypertaylorism, papilledema, optic atrophy, exposure keratitis, and visual loss. V-shaped maxillary dental arch can be seen, maxillary hypoplasia, frontal bossing, conductive hearing loss, upper airway obstruction causing respiratory distress, and acanthosis nigricans. Progressive hydrocephalus occurs in less than 1/3 of the patients. Concluding the case, initial diagnosis during antenatal period through DNA testing for mutation of FGFR2 gene and prenatal ultrasound may be helpful to indicate forthcoming developmental problems, hence providing the option for terminating the pregnancy or optimal postnatal management and counseling for the family. To prevent complications like airway obstruction and decreased vision, early diagnosis and management is important. As intelligence is not affected, patient is able to lead a normal life, as is the case of the father of this patient. These are my sources. Thank you.